Welcome to another program in the Smith, Kline & French Psychiatric Recorder series. In the next 30 minutes or so, we'll be listening to a discussion of a kind of therapy which has been variously called brief therapy, psychotherapy of brief duration, or short-term psychotherapy.
Short-term psychotherapy should not, in my opinion, be defined simply on the element of time, namely that it would be for a few weeks or a few months rather than over a longer period of time. It is much more than that. It is a treatment which is specific. It has a technique which is specific and which is aimed at certain people who are selected and to whom this treatment is the treatment of choice.
That was Dr. Peter E. Sifneos, author of Short-Term Psychotherapy and Emotional Crisis. Dr. Sifneos is a professor of psychiatry at Harvard Medical School. His interest in brief therapy stems from his association with Eric Lindemann and Gerald Kaplan during the Wellesley Project in Boston in the early 50s. There, the efforts of a number of workers in the then-developing field of community psychiatry were directed towards extending the benefits and resources of psychiatry to the greatest possible number of people, and short-term psychotherapy appeared to be one of the ways of doing this. At about the same time, at the Tavistock Clinic in London, a group of English psychiatrists and mental health workers were also studying the problem of brief psychotherapy. One of them was Dr. David Malan.
Well, I was an original member of Michael Barlin's team, which was founded in 1954, in fact, and he entrusted me with the job of writing up our work, which I did in a book called A Study of Brief Psychotherapy, which was published in 1963. Since that time, I have been working on a second series of patients also treated by Dr. Barlin's team, and I'm hoping to publish a book on it shortly.
Joining Dr. Sifneos and Dr. Malan in our discussion today is Dr. Astrid Heiberg, a psychiatrist who has been working at the University of Oslo for the past 4 years with a group of general physicians trying to outline systematically the main criteria for selection and treatment of patients in brief psychotherapy.
The main trouble that we face is that a lot of patients who could really utilize this brief therapy, really creating a major change inside themselves within a brief period, that these people do not get the proper treatment.
Brief psychotherapy, like group therapy or behavior modification or any other specific technique, is of course a complex subject, and our participants in this tape will limit themselves within these few minutes to a discussion of the criteria they use for the selection of patients. But before we specify criteria for selection, I'd like to ask you what you mean by brief therapy. Dr. Sifneos?
One could imagine psychotherapies of short duration or brief duration, which would be of a different technical, let's say, approach. For example, one may have patients who are more disturbed, yet they could be helped with a more supportive approach, even by the use of medications, or even by a different technique of therapy, behavior modification, which is also of short duration.
Dr. Heiberg, what do you mean by brief therapy?
The therapy may be brief by a number of sessions, but it may be extended over quite a long period by having sessions with a long interval between them.
Dr. Malan?
Yes, I've always thought it was very important to define brief psychotherapy in terms of the therapist's time employed on the patient. In fact, the patient has got the time. The therapist hasn't. So if you define it in terms of, shall we say, therapist hours per patient, then what we're concerned with is the use of the therapist's time in the most economic fashion. And so, one can make quite arbitrary limits for the definition of brief psychotherapy in terms of therapist hours per patient, which varies from something like a dozen that some people work with. We work in the Tavistock Clinic with a standard number of 30, in fact, which is rather longer than many people use.
So I think there might be certain differences in emphasis right there and then between the three of us. We feel that the conflict which has to be worked during the therapy and be solved has to be done over a brief period of time. So this is communicated to the patient, who immediately asks as to, when you say brief, how brief? And then instead of saying to them, well, we are going to see you 12 sessions or 15 or 30 sessions, we say, well, it would be a matter of helping you to solve your problem over a short period of time, which would be about a few months on a once-a-week basis. So I think really there are different ways of putting the problem, but I don't think there are any basic differences.
Really, the major question of all in the subject of brief psychotherapy is what is the quality of the help that you can give to a patient within this time-limited form of therapy. And in the 1940s and early 1950s, one could repeatedly read in the literature the statement that brief psychotherapy is only suitable for the least ill patients and the most ill patients. Now, this is a statement that always got me confused. And, Peter, the resolution of it, in fact, was given by yourself when you made absolutely plain that they were talking about two totally different kinds of brief psychotherapy.
Okay. We have two different categories of psychotherapy of short duration. One we labeled anxiety-provoking, because the therapist and the patient were together looking at a problem and working at it. The role of the therapist was much more challenging and was encouraging the patient, who was motivated to try to understand himself. The other one was more a different kind. The role of the therapist was more supportive. At times it was of importance for him to know the difficulties of the patient, but the patient did not have to know about them as long as the symptoms were, let's say, relieved or his difficulties disappeared.
At one end is the relatively healthy patient with whom one can use interpretation and to whom one can give a major piece of insight, who can benefit very markedly from this. At the other end, there's the very disturbed patient in some kind of acute state in which you make not the slightest attempt to make interpretations about the nature of the conflict that they're going through. This is right, isn't it?
Yes, absolutely.
And so you need to emphasize the polarity between what you, Peter, refer to as anxiety-provoking therapy at the one end and basically anxiety-suppressive therapy at the other. And these are totally different things, and the selection criteria for these two forms of therapy are totally different.
Yes, yes.
We'll return to our discussion in just a moment. First, here's a word from Smith Kline in French.
Location, the tribal state of Toma in Western Africa. Wednesday dawn, the most magical time of their week. The girls of Toma return to their village after 2 years' isolation with older women to learn the secret rites of this African society. For some time they have been filled with anxiety over their return to the group, but the village supports their return and eases their transition with processions, singing and dancing, designed to communicate essential ideas about village life. Still, a few of the young girls will have difficulty readjusting to the community, and symptoms akin to neurotic anxiety will develop. Further ceremonies will be held to reduce this anxiety, reinforce group solidarity, and ease their return to the village. In our culture, such group support of patients with neurotic anxiety is rare. Instead, the psychiatrist is asked to help. But often anxiety is so overwhelming that it is difficult to start meaningful therapy. That's when Stelazine, in low doses, can be a valuable part of the treatment regimen. Stelazine works to control chronic neurotic anxiety without producing the oversedation and hazards of drug dependence and tolerance often found with minor tranquilizers. So Stelazine is especially suited for the long-term therapy often needed in treating chronic neurotic anxiety. BID Stelazine therapy is easy to remember, easy to take, and reduces the chances of forgotten or missed doses. Compared to TID or QID minor tranquilizers, a prescription for Stelazine is an economical choice. Once symptoms have been controlled, some patients may be maintained on once-a-day therapy, resulting in additional economy.
Stelazine, brand of trifluoperazine hydrochloride, is not indicated in mild anxiety, in situational anxiety, or in cases where simple reassurance will suffice. It has been evaluated as possibly effective in patients with chronic neurotic anxiety. See the indications section of the accompanying prescribing information. Stelazine is contraindicated in CNS depression, blood dyscrasias, and pre-existing liver damage. Although uncommon at low doses, mental and physical abilities may be impaired during the first few days of therapy, and patients should be cautioned accordingly. Use cautiously in patients with angina. Physicians should be alert for extrapyramidal system side effects, including tardive dyskinesia, and for CNS depression, hypotension, hematologic effects, liver toxicity, and other adverse reactions associated with phenothiazine therapy. Please consult the full prescribing information accompanying this tape before prescribing Stelazine.
Thorazine in chronic neurotic anxiety, valuable adjunct to your supportive counseling and other therapeutic efforts.
Our discussion continues now. Here's Dr. Heiberg.
The way I see it is that you have a sort of a scale for healthiness and for potentiality to really be able to utilize insight also in an emotional way. And I think that scale for healthiness starts with these patients who can work very well and very quickly on a very high level of anxiety, like the patients you treat. And then you have a sort of an intermediate state with these more dependent patients who need a longer time to be able to really interact.
Yes, I entirely agree. There's no question that the patients that are suitable for the anxiety-provoking type of therapy are regarded as healthier than the ones who are only suitable for anxiety-suppressive therapy. This is one of the continua that we have to deal with in considering patients for brief psychotherapy, namely the spectrum of health versus sickness. There's another continuum, which is the depth of interpretation that you're going to give to the patient. Again, starting at the sickest end, you may give no interpretation whatsoever. You try to relieve the anxiety-provoking situation. You give the patient drugs to tide them over and hope that they will somehow recover. Then at the next stage, the moment you are explaining to the patient something about what you think they're feeling or their maladaptive reactions, you're surely making interpretations. At the final stage, with the anxiety-provoking type of patient, you do not pull your punches in any way and are quite prepared to interpret what one may call the nuclear conflict of the patient.
Now, David, if I were a practicing psychiatrist or a general practitioner and wanted to refer a patient for a kind of psychotherapy, how could I go about choosing between these rough three different categories? Would I, for instance, keep the extreme case and give the patient medication and, as you say, hope that medication would take over and the patient would not change in any way except that his symptoms would improve and he could function and return back to his emotional equilibrium then? Should I send the second category, where a certain degree of interpretation, clarification might be of importance, let's say, to one of us? If so, how can I distinguish between that sicker patient and the other one? The very well put together patient we can come to later on, that's not so difficult, I think. What do you think, Astrid?
Well, I'm afraid I couldn't give any easy answer to that because it depends, of course, on the person. To me, in a way, the main point is the patient's ability for contact, for interaction. And I think that's perhaps, if you're going to look for one main thing, that's the most important element, both in the interview and in the history taking. That's a key.
I think that one has to start with what amount almost to absolute contraindications for brief psychotherapy. Now, the absolute contraindications for analysis are also absolute contraindications for brief psychotherapy of the kind that we're talking about, not necessarily for an anxiety-suppressive kind of therapy, but for the more anxiety-provoking interpretative forms of psychotherapy, we would regard the following list as absolute contraindications. And it goes something like this: lifelong crippling obsessional symptoms, lifelong crippling phobic symptoms, convinced homosexuality, drug addiction, chronic alcoholism, many courses of ECT, manic depressive psychosis, and so on and so on. Repeated suicidal attempts is another one. They're absolute common sense criteria. But, we would not consider a patient who showed any of those features of brief psychotherapy. On reading the material about him, we would refer him to some other form of treatment without bothering to see him. And one must start with those. Now, when one gets beyond the absolute contraindications, then one gets into a highly complicated and highly skilled area where one can only really tell whether a patient is suitable or not by seeing him. And of course, the factor that Astrid emphasized, namely the interaction between the interviewer and the patient, is one of the crucial factors.
But that indeed comes after you're having eliminated all these other factors. And the only way to do that is by the systematic history taking. Because the history taking is the key, isn't it, for our differentiating these sicker and the in-between category and the very healthy patients.
This is important because so far really we've only talked about the contraindications.
Well, to talk about what to look for in the patients, we have tried to make this systematic, primarily based upon the criteria that Peter has set up for short-term anxiety-provoking psychotherapy. But we have extended that a bit to take care of somewhat more sick patients, but still on the very healthy side of the scale. And to take it chronologically, we start to try to find out whether we are able to define a focus for the therapy, to define a problem which seems to be possible to solve in a brief time. That sounds very esoteric because it is a self-circling statement in a way. But into that comes really the experience of the psychiatrist to be able to judge that this is a sort of problem which seems to be connected with a so conscious level, so to say. There we go into David's parameter of the depth of therapy, that it is reachable within a relatively short time. And in that comes a definition both of the problem and also the patient's ability to choose one problem over the other, which in a way leads back to the patient's motivation and his ability to choose one thing and say, if I have to choose between several different problems, I will prefer to work on this one.
The order that I start with is usually concerned with the interviewer's ability to formulate a circumscribed therapeutic plan or focus on which the therapist is likely to be able to work. And one can describe an ideal type of patient here. This is a patient who comes to one after some precipitating factor caused a disturbance in him. And you can understand the dynamic reasons why this has caused disturbance in him. You can understand the nature of the conflict. You then go further into the history and you find previous precipitating factors that have precipitated symptoms or disturbance in him, and you can see that the same type of conflict is represented in these previous events. And then you go back into his past and find that the family patterns, in fact, can quite easily be seen to conform to producing the same kind of conflict in the patient. Now, there suddenly you have ready-made for you a focus on which to work. Namely, that there is a thread running through this patient's life of, shall we say, I'm thinking of a particular patient, of anxieties about growing up into a woman. And you know that if you're going to help that patient, it is over her anxieties in that area that you must work. There, the focus is given to you.
And the next point on the scale is the interaction of the patient. How he interacts with the therapist or the interviewer, and how he can, how from the history you can judge how he has been able to relate before. He has to have the ability to really relate in a give and take position to the therapist. And one of the practical things which we have found most useful to find out whether this interaction is a solid one or not is to look for the best friend.
This is one of the criteria that Malan was always talking about. That is the history of their previous relationships, which is something that we always go into, but we've never thought in terms of saying to them, describe to me your relation with your best friend, which obviously is one of the crucial ways of getting at this factor.
And that is also often a very good starting point in the history taking. Where did you learn to relate in this way? But when he does not relate, and especially if he is depressed, that may be a difficulty, that he has potentialities to work on a higher level than he can show in the first interview. And then it is really very important to look for this best friend.
We have also used lately the term flexibility of emotional interaction during the interview, because somehow a good emotional interaction may imply that the patient should say only good things about you or about his past. But that's not necessarily so, because if indeed there is something about the interviewing situation, having waited for half an hour on the outside or something like that, and may come out with a fairly negative, realistically negative expression of feelings, this is perfectly appropriate and should be considered just as important part of the interaction, rather than hearing only the positive ones.
In fact, more so.
Yes.
Yeah.
Yeah.
This is the end of side 1. Please turn your cassette over. This is side 2 of the discussion of the selection criteria for patients in brief therapy. Here is Dr. Heiberg.
Then on the list, back to that again,
Yeah.
we look for this ability to solve problems emotionally. We put that down originally as intellectual capacity. But I think we made a mistake there, and we were stuck there somewhat because we were liable to confuse that with just intelligence.
Yes.
And somebody who would be a mathematical genius could well be not very good in pursuing his emotional
Totally
problems.
out of touch with his feelings, and in fact, the more mathematical a genius he is, the less likely he is to be
Well,
in touch with his feelings, I would have thought.
might be a difficult thing to say.
Yeah.
One of the things which we need to emphasize is that the interviewer has to be able to give problem-solving situations, so to say, to the patient. He has to say that now you say that this is so in that situation, and you told me before that with your mother you related in that way. Could you in any way try to connect these things, or these two situations, and then see how the patient is working?
You give the patient an interpretation, often quite a tentative one, and not a terribly deep one, on these subjects. Then you have to gauge the response of the patient to remarks like this. Although the first criterion is that you should be able to understand the psychodynamics and to make it into a focus, it is absolutely essential that your focus should have been tested out with the patient, and that you should have found out that in fact the kind of approach that you're going to use with him is acceptable to him, that he can respond to it.
But I think it really boils down to a good motivation. That if you really have a good motivation, almost everything else is under that. Because if you have a motivation to understand yourself, if you have a motivation to change and not to have a symptomatic relief, then indeed you would show certain of the other parameters as understanding, as problem solving, as learning new ways of establishing new patterns of behavior.
That's exactly what I should like to finish about what you said about the motivation. That is, in a way, the main thing on the list.
Yes, the thing that comes out of my research on brief therapy is that the most important selection criterion appears to be motivation. This is the third step in the assessment, that not only can you see a plan, not only does the patient respond to interpretation based on your plan, but he wants to work with this plan, and this is very different just from responding. And the fourth criterion, which also is extremely important and comes back to what we were talking about earlier, concerned with the contraindications, is that you've got to cast your mind forward into therapy and think of the possible dangers of using this interpretative approach with the patient. And there are many patients whom we've rejected because, one can see perhaps that in fact that although the patient may be responding very well, although you can see the focus, the patient is potentially extremely dependent, and that you're going to get involved in a dependent transference which is going to be traumatic to get out of. In spite of the fact that all the other criteria are favorable, I think that you reject such a patient, or one whom you can see there's going to be a great deal of destructive or self-destructive acting out or something of this kind, in spite of the fact that all the other criteria are favorable. This patient is not suitable. Patients who are potentially pretty disturbed and there's no support in their environment. One has to use one's psychiatric, psychotherapeutic experience and one's common sense not to accept patients with whom these dangers seem inevitable. You can foresee dangers, and you can foresee how you think you can avoid them. And that's all right, you can take those patients on. You can take patients on as a calculated risk. For instance, if there are, psychotic features in the patient, and you feel that by dealing with the relatively surface layers of the patient's pathology, you can keep off something which will precipitate them into a psychosis, then that's all right too, but you must have foreseen it. Now, those are our four criteria: that you can see a focus, that the patient responds to interpretation based on the focus, that the patient has the motivation to work with this focus, and that various possible dangers don't seem inevitable.
May I just emphasize one thing, and that is about motivation, because we discussed that quite a lot, and we were stuck with the question, motivation for what?
Absolutely.
And the
yes.
answer is motivation for change, that the emphasis should be underlined, so to say, on change.
Yes, I don't entirely agree with that. I think the motivation should be for the kind of therapy they're going to be offered. It should be put in terms of the process of therapy rather than the outcome. I agree that motivation for change is perhaps an important part of it. But the one that we emphasize is motivation for insight. Forget about the change. We hope that change will follow from the inside, but that they want to work in the kind of therapy that you're going to offer them. Perhaps that's a slight difference of emphasis between the two of us.
I believe it's only a slight difference, because
Yes.
but if you are really going to get insight, that insight should lead to something, and it should lead to your ability to change your behavior or your attitudes or something.
Yes.
And to change also implies that you lose something. Even if you have the loss of something which is undesirable, it is a loss, and loss is painful, and it is accompanied by anxiety.
Yes.
So the patient is willing to pay the cost of the change.
I quite agree with
In the beginning, we had a special interview assessing motivation. I used to have an interview with every patient that was accepted for psychotherapy, to assign to various therapies and things like that, and therefore it was up to me to spend this extra time to be absolutely certain as to whether the patient was motivated for psychotherapy. For better or for worse, we came down with 7 sub-criteria.
What's the first?
The patient's ability to recognize that the symptoms were psychological, or that the difficulties, the complaints that they had were psychological in nature. I mean, if somebody, for instance, came in with a pain in the stomach, and it appeared to be that the pain in the stomach was associated repeatedly with difficulties that he had at his work with his boss, and that the various investigations have been negative, his insistence that there was something wrong with his stomach, or his consideration that there might be possibly certain emotional factors, such as the difficulties with the boss, that may have something to do with the pain in the stomach, was of course of crucial importance. Another one was that the patient should be willing to work hard in the psychotherapy. And that's another way of putting what David was saying a minute ago, to be able to see paradoxical connections, to be able to bring in further associations or information about certain aspects of a question that the evaluator has raised, even if he sees no relevance about it.
Yes. What about the next one?
A willingness to experiment, a willingness to somehow go on a wrong limb to see that there might be something in it. Again, this is another way of saying the paradoxical situations. Another one is a curiosity about oneself. Now, since you, as the evaluator, asked a question about me, well, indeed, that's of interest, because I have been curious about this aspect, but I never thought to put it in the way you do, and which reminds me of that there's another thing about myself which I don't understand. If I could only try to, etc.
And what about the next one?
A basic honesty that one has in trying to present things as they really are, even if these things are unpleasant, rather than trying to camouflage or run away, or easy solutions or pleasurable aspects of dealing with a problem, which of course, as the therapy goes on, one is constantly confronting the patient. This is why I chose, I don't like the term very much, but anyway, the term anxiety-provoking. The other two, the last ones, the sixth one has to do with expectations as to what is going to be achieved, whether these expectations are going to be global or whether they're going to be realistic as to what the focus has been. Well, I could give you an example of the patient that came in and told me that he appeared to be motivated up to the point when I asked him, well, now what is it that you would expect as a result of the therapy? And he said, well, I would like to get the Pulitzer Prize. And I said, well, that's very good, but what have you written? So you're a writer. And he said, oh, no, I'm not a writer. I would like to learn how to write. I have the potential to write, and you can help me, and then I would get the Pulitzer Prize. Well, as you can see, that's a little bit exaggerated. Expectations are unrealistic. The final one has to do with a tangible sacrifice. How much is he willing to pay for this whole list of problems that he has?
One of the patients that came to Balin's workshop came to a health service place, not fully realizing that it was only health service. He said, "I've saved £50. It's all I have. I want 25 sessions. £2 was standard price in those days." That was motivation. Mm-hmm.
Yes.
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 But then for outpatients, quite practically, for people who are working in offices or somewhere else, I think a good test for motivation is whether they are willing to make the necessary arrangements so that they can come during daytime to the clinic, or make some arrangements at the place where they work so that they are really able to come to the sessions. And for
Can I say, Astrid, I entirely agree with that one, although I sometimes think it's a little unfair to expect a patient to go to his boss and say, I'm going to have psychotherapy, and can I have 3 hours off during the day? If they're willing to do it, it's a very good test of motivation. If they're not willing to do it, it doesn't necessarily mean poor motivation.
But they should usually be able to try to do that.
Absolutely.
The only exception I make on that anyhow is for teachers, because it's really such a difficult problem to change, and teachers are quite frequently coming into this because they would be sophisticated and informed persons. And then for the housewives, I think a good way to test it out is whether they are willing to make arrangements for babysitters, which is really very often a practical question.
Yeah. I'm just thinking of sort of other ways of judging motivation by various actions of the patient. Now, I'm thinking of a very high executive who broke down into severe anxiety, who never really looked at his feelings at all during the course of his life. One gets many such patients here, and I think you probably do in the States as well. And during the course of his psychiatric interview, it was put to him that he was breaking down into anxiety because he had never looked at his feelings, and in particular, he'd never looked at his feelings about the death of his mother, who had died, say, 1 year before. And the next time he came up, he said he had deliberately gone and slept in the room where his mother died in order to try and capture his feelings about his mother's death. Now, that's motivation.
Yeah. Well, I'm very glad that you brought these things, because what I wanted to emphasize quite clearly before when I was listing these sub-criteria for motivation was not simply to ask somebody a question whether are you willing to participate actively in the treatment, and the patient says yes or no, but rather than to give specific examples. And this may apply to the other criteria that Astrid listed before, for instance, about having a best friend. If you ask somebody, well, now, do you have a best friend? And the patient says yes. Well, we are not going to be satisfied with that, but we're going to say, now, can you give me an example? And again, the example is going to convince you whether he does or he doesn't. And the patient will be unaware, you see, of what is a good example to give, if indeed he never had a good friend, meaning that he was never willing to make any sacrifice for another person, but the only thing that he was interested in friends was to get from them rather than give anything in return.
Our discussion will continue in a moment. First, a brief message from Smith Kline in French.
India, land of yoga, meditation, and tradition. A society which for thousands of years has placed a high value on introspection, introversion, and emotional control. It's not surprising, then, that the majority of schizophrenics in India are withdrawn. In fact, catatonic rigidity, negativism, and stereotypy are also quite common among Indian psychotics. In our culture, though, symptoms of agitation, anxiety, and even violence are often found in schizophrenic patients. It is for these patients that Thorazine, chlorpromazine, SK&F is especially useful. Thorazine offers effective control of psychotic symptoms, including hallucinations, delusions, and anxiety. It calms agitated hyperactive patients and helps improve their disordered thoughts and perception. Thorazine helps you establish a functioning relationship with patients. From psychiatric emergency through maintenance therapy,
Thorazine, with 18 dosage forms and strengths, allows you to tailor medication to the patient's needs at every step of the way.
Thorazine, chlorpromazine, is contraindicated in comatose states in the presence of large amounts of CNS depressants and in the presence of bone marrow depression. Avoid using in patients hypersensitive to phenothiazines. Caution patients about activities requiring alertness. Avoid concomitant use with alcohol. Use cautiously in persons with cardiovascular, liver, or chronic respiratory disease, or with acute respiratory infections. Aspiration of vomitus is possible. Thorazine may prolong or intensify actions of CNS depressants. Patients on high-dose long-term therapy should be evaluated periodically for possible adjustment or discontinuance of dosage. Physicians should be alert for extrapyramidal system side effects, CNS depression, hypotension, hematologic effects, liver toxicity, and other adverse reactions associated with phenothiazine therapy. Before prescribing Thorazine, please consult the accompanying folder for complete product information, including indications, contraindications, warnings, precautions, and adverse reactions.
Thorazine, because a calm schizophrenic patient is more receptive to therapy.
Our discussion continues now. Here again is Dr. Sifneos.
May I ask you, either of you, how many interviews do you feel should be involved in the evaluation? Would you have more than one interview?
I might. It's again a question of interaction. With one of these very good patients, I had to work to keep in pace, and then one interview was enough, and you could say even half an hour might have been sufficient. The more in doubt you are, and the longer time you need to assess interaction, in a way also tells that the patient is of a somewhat sicker quality.
It may not be sicker, it may be they're more highly defended, and what you've got to try and assess is whether or not they are willing or able to drop these defenses.
Right. And depressed patients may also be somebody who you need a bit more time for. The main difficulty about depressed patients would be that you get a false impression that they would not be suitable.
That is not true. That is not true. Certainly there are two kinds of depression, as we all know. The endogenous depression, which of course is contraindicated for short-term psychotherapy, and as you discussed the contraindications before, that was one of them. But certainly depressed patients are, in my opinion, very good candidates for short-term psychotherapy, particularly for an acute onset.
And if it's in response to, in fact, to any identifiable external event, if it is reactive depression.
Yeah.
But I think usually more than 2 interviews would not be necessary to judge whether you should offer brief or insight-oriented dynamic psychotherapy with these or not.
I entirely agree with Astrid that there are certain types of patients that you can really tell at once. There are others where you may have to go through quite a prolonged process in order to convince them that your approach is going to be of value to them. And with those, you do need more than one interview. I routinely refer my patients for projection tests before I finally accept them. And sometimes you get a shock when the results of the projection test come up. I'm thinking of a particular young man who he was interviewed by a man. He seemed to have very clear problems in relation to older men, and it seemed absolutely clear that an Oedipal focus could be used with him. He was then given projection tests by a woman, where he revealed a quite paranoid attitude towards women. Now, because he'd been interviewed by a man, this had never emerged, and we dropped him. So ideally, I think you often do need more than one interview. Just the same, it may not be practically possible.
We have emphasized the necessity for the majority of the patients to arrive at some pretty good picture at the end of one interview. If indeed there is a question, this question should be specified quite clearly, and that if it is specified in psychological tests, which we don't use so much, are needed, fine. But I think we are all in agreement that these good candidates for short-term psychotherapy that move very fast, that one interview is all that is needed for the majority of the cases, and that for the others then we may have to have more interviews, a variety of interviews, as David suggests, to evaluate some of the more complicated issues.
Yes, I agree with that.
Thank you, Dr. Malan, Dr. Sifneos, and Dr. Heiberg. This discussion of the selection criteria for patients for brief therapy is another in the Smith, Klein, and French Psychiatric Recorder series. brought to you as a service in continuing education in psychiatry. This program was recorded in London and produced for Smith, Kline & French by Borland Coogan Associates Incorporated, Philadelphia. The views you have just heard are, of course, those of the individual participants themselves. Participation by our discussants is not intended as an endorsement of Smith, Kline & French products.